difficult to wean from ventilator, what do I do? Our speaker is Dr. Rajesh MG. He is Additional Associate Professor of Pediatric Cardiology at Amrita Institute, Kochi. And we have our chairperson, Professor Shumantro Sarkar, who is the HOD of Diamond Harbour Medical College. So please, sir. Time after 20 minutes time.
Change what?
Hello. Good afternoon. Here is the next session. Myself, Professor Shumantro Sarkar, HOD Pediatrics, Diamond Harbour Medical College. I am privileged to be here in the part of the critical care conference, though I am not a critical care person, but here I am thankful to the organizers, especially Mihir and Provash. Our next session is difficult to wean from ventilator. What do I do? The speaker is Dr. Rajesh MG. Hello, Rajesh. He's MD from PGI and DM from Sri Chitra Institute. Now Associate Professor, Cardiac Anesthesia in the AIMS Kochi. And his area of interest, the lung USG and pediatric critical care. So with this, I hand over the mic to Dr. Rajesh.
Thank you, sir.
We'll be hoping.
Thank you for the kind introduction, and I thank the organizers at the offset for giving me an opportunity to talk on this platform. So today I will be briefing on the approach that we follow when we deal with stuck on ventilator babies. So literature wise, they define it as the re-intubation happening after a planned extubation. I repeat, a planned extubation, because if it is an unplanned one, the chances are as high as 50%. So following a planned extubation, some define it as 24 hours, for some it is 96 hours, and for a few it is even like the usage of an NIV modality. But in cardiac setup, you cannot define that way, because most of the babies, especially neonates, we bridge with a NIV modality after the immediate post-extubation period. So practically you can define it as the re-intubation happening within 48 hours of extubation. And it is very relevant in our low middle income country setup, because in addition to the cost and the morbidity and mortality, it's a big trauma for the parents as well, seeing their babies going on repeated re-intubations. So I'll just share our statistics. It's a decade back published data for 4 years, did around 595 cases per annum, and at that time we had around 8.4% of failed extubations. And I just compared it with our last year statistics, where we did 749, better than before, big number of cases, and we had only 6.4% of the failed extubations. And you need to know that both these occasions we had a bed strength of only 10. And our surgical anesthesia perfusion didn't change much. And with the improved result, what I can say is that we made some changes in our critical practice, and I strongly believe that that is a reason for this one. I will discuss in the subsequent slides. Before that, let us see what the literature says. Say a study from 2017, the author included 14 centers, 899 neonates, and they have a high risk, independent risk factor of airway anomaly. That is not the point. The point to note here is that, see the range of this extubation failure. It is from 5 to 22. What does that mean? So there are centers who are still having scope for improvement in their extubation practice. Another study, 2015, and 8 centers, around 1,500 patients, 5.8% of risk factors, failed extubations, and independent risk factor, the more you ventilate, higher the chance of extubation failure. In that study, 1/3 of the patients got extubated on table, and see the results. Failure is only 3%. So that again reinforces the fact that you should try to find an early window to extubate the babies whenever possible. And 2016, another study, big cohort, 62 centers, around 27,000 babies. Here also 1/4 of the babies got extubated on table, and their failure of extubation rate is only 6%, better than those who got extubated in the ICU. And one thing to note is that the lower volume centers is an independent risk factor, and doesn't matter, even if you're dealing with a low volume cases, still you have to find each opportunity to refine your practice for the betterment of this extubation trial. One more study, the same finding around 7 center, see 8 to 23% of the range. That means still there is scope for improvement. And they define uncuffed tube, yes, that may be injuring the upper airway. Similarly, if you keep the sternum open indefinitely, you tend to give a lot of relaxants that lead to diaphragm weakening. I will discuss in the subsequent slide regarding the same. So most importantly, all these studies have shown that the reintubations happens in the first 24 hours, almost for 60 to 80%, and 1/3 of those happen in the first 6 hours. So whenever you are dealing with a high risk extubation, you have to be very vigilant during the first 24 hours. And what if after the first reintubation following extubation, is it going to be uneventful? Definitely no. Recurrent reintubation chances are very, very high. And most of the time, it is the respiratory as well as the cardiovascular etiologies. And most important thing is that the mortality as well as stay outcomes are going to be much worse after the recurrent extubation failure. So whenever dealing with a first extubation failure, you have to be really careful and well planned to go ahead with the next attempt. So are there any defined criteria or indices as surrogate marker for the extubation failure? Basically, these are all based on the adult studies. You cannot simply extrapolate to our population. There is one study, 2000, they have mentioned few of the airway parameters and they defined some cutoff, but that couldn't be replicated by the subsequent authors. Interestingly, they are mentioning RSBI as an not a predictor for the extubation failure. Same defined by subsequent authors. Basically, because the diaphragm being the strongest muscle, when it weakens, accessory muscle tend to negotiate for some time where you measure an RSBI, but that effect won't be a prolonged one to sustain a successful extubation outcome. Leak test, definitely you can do, but whenever you ventilate a baby chronically, mucus tend to accumulate on the outer part of the endotracheal tube and will give you a false negative leak test. And also leak test, you need a supine patient with without much spontaneous effort. It's not going to happen when you're extubating the baby. So at the end, you don't have any much clinical parameters to define that. And organ specific wise, there are a lot of risk factors defined in the theory. I'm not going into details of this thing. So at times what happens, you may get a baby without any of these risk factors. Straightforward case, short pump run, short clamp run, and postoperatively VAS score less than 15, no arrhythmias, but still once you wean, you tend to fail. Why? So you need to know, basically the success of extubation is the interplay of these 5 organ systems. And in that, all these risk factors ultimately come into this. And in that, for the cardiac, it is basically the relation between the heart, the lung, and the diaphragm. So you need to know how to scan these things in a fine way. Going back to the basics, positive pressure ventilation, it reduces the stroke volume, reduces the RV preload, afterload, and LV also gets less volume. LV afterload, because of the transthoracic pressure, the transmural pressure for the LV is less, LV afterload is less, favorable for LV as well as the RV, workup breathing is less. So altogether, lung and heart are comfortable. But once you start the extubation attempt, everything tilts. Afterload for the RV as well as for the LV is high. Because of that, LA pressures tend to go high, and that need to, compromised ventricles, it lead to pulmonary congestion, and identity called as the weaning-induced pulmonary edema. In addition to that, when you have a low cardiac output, the blood supply to the diaphragm compromises. And when you are weaning, diaphragm is the skeletal muscle that needs maximum blood supply as well as the oxygen. So that demand is not met. And what happens? Diaphragm goes for an anaerobic metabolism. Lactate tend to accumulate and acidosis, okay, to wash out that. Diaphragm has to again work more for PCO to wash out. So without much blood supply, diaphragm is made to work like anything that lead to diaphragm dysfunction. So altogether, this is an interplay between these 3 organs that you need to know where things are going wrong. So we'll see one by one. So many of you should be knowing echo. You may be using it for screening, eyeballing for the function, filling status, SVR, PA pressures, etc., etc. That is not enough. So extubation failure, the cardiac etiology, 2/3 of the time, it is the diastolic dysfunction. So it's not possible to discuss the whole thing in one session. You may be knowing systolic function assessment, but using the ejection fraction as well as fraction shortening. But neonates, the endocardial border delineation is not always possible. So you may depend upon MRDP by DT. So I'm not discussing, I'm skipping the systolic part. And as I told, diastolic in one slide, never possible because of the time restriction. Still, you put a pulse wise across the mitral annulus, you will get E as well as the A. And if the E by A ratio is less than 0.8, you are dealing with a grade 1 diastolic dysfunction. And grade 2, they tend to be normal, and stiff LV, grade 3, you have E by A ratio more than 2. And you assess the pulmonary venous profile, that also there will be progressive blunting of the S wave, and air reversal velocity tend to go high, even more than 35 milliseconds. And similarly, the mitral annulus, you profile the tissue Doppler, you will get something called as the E prime. And E by E prime goes more than 10, and the E deceleration will be less than 160. If you are interested, you can read about these things, and I am sure that this is definitely going to help when you are clueless about the etiology for the extubation failure. Most importantly, the same thing is applicable for the RV as well. And many of the times, you may be dealing with a straightforward intracardiac repair, and there is no transannular patch, not in jet, normal lactates, and normal output. Everything is normal. Once you start weaning, they tend to behave in a bad way. And many of the times, this may be due to underlying diastolic dysfunction for the RV as well. And not only the diastology as well as histology, sometimes evident lesions may be there, like post-operatively you may have a residual MR, residual VST. You may have to go by surgical as well as intervention management. Peer pressures, residual peer pressures, yes. In addition to the conservative measures, you may have to ventilate the baby. Single ventricle, maintaining the balance of the pulmonary blood flow, ventilation is crucial. And whenever you have diastolic dysfunction, you will have to continue ventilation for some time. And same goes to LV systole function as well. And RV systole, many times they behave better once you extubate the babies. So that's about the heart. Next comes the lung. So as I told in the beginning slide, that we got some improved outcome, and I strongly believe that it is the lung scanning. We started 2.5 years back, and we are using this linear probe, and I'm telling you, like most of these lesions start in the posterior region, in the interscapular region, and because of the mediastinal shadow, that won't be evident in your X-ray, and by the time you detect, it will be too late. So this way, we are able to pick most of the pneumonia. We send an early ball, and we start timely antibiotics. They resolve. Same way, collapse, we can tend to recruit it on like real-time basis based on the lung ultrasound. If you have an effusion, you can decide whether quantify the effusion, and you can decide whether you want the drain or diuretics are enough or not. So we scan total 12 segments, 6 on either hemothorax. This is not part of discussion. This is separate topic. So I would like to tell that there is a study in 2016 where the author had made a grading based on the lung ultrasound. So there is grade 0, 1, 2, 3, 4, 3, sorry. So grade 0, normal lung, no much B lines. Grade 1, mild to moderate B lines. Grade 2, coalescent, severe B lines. And the grade 3, whenever you have consolidation or the collapse. So cumulatively, the score for 12 segments maximum will be 36, 0 to 36. So whenever you have the cumulative score for the whole lung, if you get it is less than 13, most of the time you are safe from the lung aspect. However, if it is more than 17, you are dealing with a bad lung. So when you have a pneumonia or collapse, as I told, scan the lung, send an early ball, start antibiotic on time, continue vigorous respiratory therapy, and if a score is more than 17, you are dealing with a difficult ventilation, weaning attempt, and at times you may have to prone based on where the lesion is, you may have to take a bronchoscopy if there is a occlusion of the airway, and you may need frequent spontaneous breathing trials. At the end, whenever you extubate, most of the time you may need a non-invasive modality for bridging the immediate post-extubation period, the 24 crucial hours. And apart from the heart and the lung, important thing is the diaphragm. This is a 3-layer structure lying between the lung and the abdominal visceral organs. So you can use a linear probe kept at the anterior axillary line on the 9th or 10th space to scan the diaphragm, like I shown in the previous slide. Many of should be knowing the excursion, that many of commonly mention the excursion. And here the value is around 15 mm. Yes, that is normal. Excursion, anything more than 10 to 14 is normal. But the problem is that, the fallacy is that if you have a PEEP and if you are giving a positive pressure, excursion may not be that reliable. So need a better alternative. So we'll see what it is. So here you compare. This is a very thick diaphragm, and here you are seeing a very thin diaphragm. So what is happening? Whenever you ventilate a baby, a neonate, more than 48 hours with frequent relaxant administration, as I told in the beginning slide, that leads to something called as the ventilator-induced diaphragmatic dysfunction. This is a very common cause for the extubation failure. So how can you detect it? you just put the M mode across where you have scanned the diaphragm, and you can get something called as the diaphragmatic thickness fraction, also called as the ejection fraction of the diaphragm. So inspiratory thickness minus expiratory times expiratory. If the ratio is more than 36%, you are safe, and if less than 20, you may get stuck with the ventilator. And whenever you have frank diaphragm paresis, you have to continue routine vigorous therapy, and at times you have to tilt the bed a little more high up to 45-degree respiratory therapy. And if you are prolonging the ventilation, mind you, put on SIMV and avoid or reduce relaxants, because it will avoid the entity of VIDD. And if you have symptom relief, yes, go ahead with extubation, and otherwise you may have to placate the diaphragm. At times, if you have bilateral diaphragm palsy, placate single side and see how it behaves. It may even end up in tracheostomy if it is beyond 3 weeks post-diaphragm plication. And effusion, pleural effusion, another culprit. And this is a collapsed lung beneath the effusion, but at times, the lung may even be expanded, but still you will get a trouble. It is because if you have a fluid, there will be uncoupling of the lung parenchymal and the thoracic as well as the diaphragm activity. That also at times lead to failure. And also, when you have fluid overlying the diaphragm dome geometry changes, and that also prevent diaphragm from working at its the best. Upper airway scanning, yeah, it will help. So we use the linear probe for that. If you put on the thyroid cartilage, beneath that you can see the vocal cords. And if the mobility is altered, you can very well detect that. And that proves that it is a high risk for aspiration followed by pneumonia. But the key role is not played by the vocal cord palsy. Most of the time, it is due to the narrowed lumen. So if you have an airway stenosis, doubt of it, you may have to go ahead with the bronchoscopy as well as the CT. And if the diameter is less than 50%, and it is in the trachea, you may go ahead with a sliding tracheoplasty. It is just beneath the glottis, you can go ahead with a cricoid split. And if diameter is not that bad, continue routine therapy. And if narrow segment is in the trachea, upper trachea, you can just advance endotracheal to the narrowed point. And if it's lower down the bronchus or the distal trachea, you can even use a stent if you cannot bail out. And at times they end up even in tracheostomy. So that's it. Whenever you, no matter whether it is a high-risk case or normal one, try to use regional anesthesia whenever possible. Like we use in our bilateral erector spinal block, so you can cut down on the polypharmacy for the pain in the postoperative period. That definitely helps. And the same way, whenever you go for frequent SBT trials, what happens? You interrupt the feeds. That also alternately advise the outcomes. And the same way, sepsis, you have to screen for that. Timely start antibiotic, that also helps for the outcome. And as I told, first 24 hours is really crucial. When you are extubating such babies, make sure that they get adequate sleep, and music definitely has got a role, and try to involve parents at the earliest with those babies, and try to reduce the polypharmacy. So that's it. So you should master the skill of learning the interaction between these three organs, in addition to minor factors like the nutrition, sepsis, neurology, etc. So you will get a better result with the high-risk cases. Thank you.
Thank you, Dr. Rajesh, for wonderful insight into the topic. I must invite one or two questions from the audience regarding the issue. Yes, sir.
Wonderful talk, Rajesh. I'm Dr. Anil Sachdev from Gangaram. I'm doing intensive care and pulmonology. So, whatever causes you have said, absolutely correct. One thing which I have learned over the years is a detailed history before patient goes to the surgery. The cardiologist or the cardiac surgeon should always ask the leading questions regarding the respiratory symptoms in the patient. You see, there are many times when there are, subtle features like mild stridor, some noisy breathing, which because of the cardiac, the parents usually forget. They don't pay much attention to these things. And these are the kids, who may have associated airway anomalies. So I have seen many times whenever there is a truncus or, interrupted aortic arch or double aortic arch, many of these cases, now as a routine, we are doing pre-surgery bronchoscopies, diagnosing, and if there is a tracheal stenosis or long segment stenosis, so we are doing slight tracheoplasty as well as the surgery in one
Prior
go.
to
Yeah.
surgery.
So we have done about more than 30 cases, and we are doing pre-op, intra-op, and my surgeon does the airway surgery, and I am there in the bronchoscope inside the airway, and I tell him, okay, this is done, so now you do whatever you want to do.
Okay.
So this is very important that pre-operatively, leading questions should be asked to the parents to prevent extubation failure.
Yeah.
So if there is a subtle thing and we have intubated patient for 48, 72 hours, so we have added something to that subtle problem. So that way we can prevent the extubation failure. Rest of the things you have done very well. Thank you.
And one more thing is there, sir, what happened last week we did a case. The same way as you told, history was, like the parents were asked for the history. They denied because it was a precious child born after 13 years, and they thought like if they say anything about the stridor, it's going to affect the surgery. We took the baby, unable to intubate, and they couldn't secure the airway. Finally, we had to wait on table for 4 hours when treating the baby just with a mask. Took back, and it was a tough case, and luckily didn't have any spells. But however, in the ICU had severe stridor, ultimately end up in the tracheostomy pre-surgery. So that's it. That history is very important.
Okay. I have one question for Dr. Rajesh, that you have told there are some metabolic causes like hyponatremia, hypocalcemia, hypomagnesemia. How do you relate to these causes to that extubation failure?
Yeah, that's what. So whenever you have the phosphates, these micronutrients, phosphate, these electrolytes, they all, like the sodium potassium pump, the ATPase pump, they all has to work based on this electrolytes balance for the finest activity of the skeletal muscle diaphragm. So whenever anything, like for example the nutritional aspect, including the micronutrients, same way sepsis, if you have sepsis, how sepsis goes, because sepsis can lead to severe low-cardiac output, thereby it can compromise the blood supply for diaphragm. So I strongly believe I usually scan for almost all the babies. So the thick diaphragm always gives so much relaxation.
Yeah.
So
Thank you for the insight. Is there any question from the audience?
I have a comment. Where did you learn this voice modulation? Your voice modulation is absolutely fantastic.
Thank you,
and
ma'am.
that is why your talk was enhanced.
thank you, ma'am. Thank you so much for
Thank you very much.
Thank you.
Thank you. Now I would like to request Dr. Shananda Mukherjee to hand over the mementos to our chairperson. Next.